Okay, my topic is on infertility with adenomyosis. How can HIFU help? Now, I think all of y'all are experts in HIFU. I have just started doing HIFU, so I'm going to give some of my thoughts about how HIFU will be helping patients with adenomyosis. This is my disclosure. I run a HIFU center at this hospital, Makota Medical Center, Malacca. Now, when we talk about principles of HIFU ablation, when we ablate fibroids and adenomyosis, it's different. I think all of you all know, but for those who don't do HIFU, this will be interesting. When we ablate fibroid has got a capsule. So when we ablate it, we can ablate within the capsule and get a good ablation. But this is not the same for adenomyosis. Now, if you do adenomyosis, you can see that adenomyosis is all over the place. And when we ablate, it's very difficult to get to the correct places to do the ablation. And that is a challenge that we have when we do ablation for adenomyosis. Now, the difference in performing HIFU for patients who want to conceive and do not want to conceive differ. Because in patients who want to conceive, we can do extensive ablation. Although my teachers teach me that we must not ablate the endometrium, but if the patient is not trying to get pregnant, why bother? Ablate everything. And the success rate for reducing symptoms such as menorrhagia and pain is good because we are ablating a large extent of the adenomyosis. Whereas when we are doing ablation for patients who want to conceive, we need to be more careful. We need to avoid ablating the endometrium. And in these cases, the ablation will be limited. The success in reducing symptoms will be lesser, and the energy that we give is also lesser. I think most of you all know about it, those who are doing HIFU. Now, the challenges are that not all adenomyosis cases are the same. And in some cases, there is a gap between the adenomyosis and the endometrial cavity. And in these cases, the chances that you will reach the endometrial cavity is lesser. In other cases, the adenomyosis actually reaches the transformation zone, the junctional zone, and it's easy when you ablate to reach the endometrial cavity. So it's very difficult to control the energy so that you don't reach the endometrial cavity. But in my mind, I'm always wondering if an adenomyosis has already reached the endometrial cavity, it's already affected the endometrial cavity, it is already diseased, why not we ablate it? Will that help the patient to conceive? So like this, in this case, you can see that the adenomyosis has already reached the endometrial cavity. And when I was ablating, I actually involved the endometrium. So am I actually affecting the patient's pregnancy? This has always been a problem for us doing HIFU. Now, this is my experience. I started HIFU in just about 2 years ago. In next 2 days will be my second year anniversary. And I've done up to a few days ago, 432 cases, about 160 adenomyosis and 270 fibroids. So we are still evolving. I'm still evolving. I'm still learning from my experience of performing HIFU. Now, in my mind, there are different groups of patients with adenomyosis who wants to do HIFU. The first group is this group who are not keen to get pregnant. These are easy to do. Those patients who have completed their family and those who don't want to get pregnant, ablation is very easy. But I am a fertility specialist, so I am concerned with those group who actually want to get pregnant, those who are keen to conceive. This is the group that is very challenging. And I divide this group into 3 groups. The first group is the one who has frozen embryo. The second, the patients who are still single. And the third is the patients who want to conceive spontaneously. So these are 3 groups of patients that I deal with. Now, I'll go on to the first group, which I like very much, which are the patients who have frozen embryos. These are patients who actually have done IVF, have done embryo transfer, and did not conceive. And then they are sent to me to see whether I can help them to do IVF, HIFU, and then help them to get pregnant. I give you an example of such a patient. This patient, let me see. Now, in this group of patients, we need to be very careful. In the ablation, we cannot ablate the endometrium. And usually what I do is I give them GnRH for 3 months. And after 3 months, I will plan them for embryo transfer, irrespective of whether the patient has got her menses or not. This is what I've been developing this policy. Now, I'll give you an example, a case study. This is Madam CLF, a 35-year-old lady. She's been married for 5 years with no children. In 2019, she underwent IVF. She had 2 embryos. She was given a dose of GnRH analog depot. And then in 2020, she underwent laparoscopy. And she was given GnRH again for 2 months, and then she had an embryo transfer in June 2021. And she did not conceive. So she was sent to me she was complained of severe dysmenorrhea and heavy menses. She was on tranexamic acid to control her bleeding. Now she was sent, the uterus was 16 week size, and the ultrasound showed a large posterior adenomyosis measuring 9 times 10 times 8 centimeters. And this is how the adenomyosis looked. It was a large adenomyosis, or more on the right side. The uterus was about 16 week size. So this is the transverse view. You can see that the adenomyosis is more on the right side of the uterus, but it was involving the endometrial cavity. So we did HIFU in September, 2nd of September 2021. This is the treatment regimen that we used. And this was MRI done 3 months later. It shows that the adenomyosis was fairly well ablated. You can see that it's fairly well ablated. And this is the transverse view showing the ablation. The ablation was fairly good, and the uterus was small in size. And this is the volume of the uterus at the beginning of the cycle. It was 940 centimeter cube. And then after 6 months, it was 265 centimeter cube, a volume reduction of 71%. So I actually sent her back to a IVF specialist for frozen embryo transfer. Her IVF specialist repeated the CA125. It was still a little bit high, so she gave her GnRH analog again. And then she did a frozen embryo transfer, and she did the frozen embryo transfer without bleeding. Those who do IVF will know that usually we start the frozen embryo transfer from the time of periods, but this one, there's no period. We just started the Progainova and then did the embryo transfer on the 25th of June. And then recently she delivered a baby by cesarean section. This is the patient. She allowed me to show her photograph. And this is not the first case. I have actually got 5 cases so far. This is my series of 5 patients in the last 2 years. And out of all these 5 patients have had IVF, failed IVF, and then they came and did HIFU with me, and then we did the embryo transfer, and then they got pregnant. 2 of them have already delivered. The other 3 are still ongoing. So what is the difficulty in patients who like this? The first difficulty is to decide which is the best time to do the embryo transfer. Nobody could tell me which is the best time to do a frozen embryo transfer. In my practice, I give them GnRH for 3 months, and after the 3 months, usually the uterus is fairly small, and that should be the best time to do the embryo transfer, provided that the CA125 level is low. And sometimes we can extend it to about 6 months. And when the uterus is at the smallest size, this is probably the best time to do embryo transfer. So next is patients who are single. I think single patients are very difficult because we need to be very careful in their ablation. I also give them GnRH for 3 months. And then I ask the patient to take put in either Mirena, take Dynogest, Depo-Provera injection, or take oral contraceptive pills. Because as you all know, when we ablate adenomyosis, we are not ablating 100%. At the maximum, maybe 70% we are lucky. The remaining adenomyosis is going to grow back. So they need some add-back therapy to prevent recurrence. And sometimes we use also Implanon. This is an example of a patient with severe adenomyosis. And after the ablation, after 3 months, the adenomyosis has shrunk. But I'm worried that she will get back the disease. The last patient group of patients are the patients who are single, and these are the patients who want to get pregnant on their own. And so this is an example of a patient before HIFU, after HIFU, and at the beginning was 382, and at the end was 312. So I'm now waiting for her to conceive. So the patients who are keen to conceive, you need to be very careful. The ablation, you need to give GnRH analog, and also if they cannot get pregnant within 6 months, I will encourage them to do IVF because the adenomyosis is going to come back. So this is an example of a patient that we did HIFU, and we are waiting for her to conceive. Okay, again, this is the finding. So I'm running short of time, so I'll conclude. Adenomyosis is a very difficult problem. It is more difficult when the patient wants to conceive. Studies have shown that success rate in reducing menorrhagia and dysmenorrhea is up to 85%. Not all adenomyosis are the same. In some, the ablation is easy, but in others, it can be very difficult. In women with adenomyosis who have difficulty in conceiving, especially who have failed IVF, HIFU is a good option to shrink the adenomyosis before frozen embryo transfer. There are many challenges in performing HIFU for these patients, including how much to ablate and how to avoid the endometrium. And the next difficulty is to decide when is the best time to do the frozen embryo transfer. So my suggestion is actually at 3 months post HIFU. And we can also use CA125 to decide which is the good time to do the frozen embryo transfer, and do it when the CA125 is normal. So HIFU can also be done in patients with adenomyosis who want to conceive spontaneously, but she must prepare to repeat the HIFU if she did not conceive and the adenomyosis recurs. Nowadays, when I see a patient with adenomyosis and infertility, I encourage them not to waste time. Do IVF. And after the IVF, we do HIFU, and then give them GnRH, and then do the frozen embryo transfer. If they still, if they want to get pregnant on their own, we will let them give about 6 months, and then advise them to do IVF. Thank you.
感谢思华教授的